What's up, everyone? Today we'll practice a set of NGN NCLEX-RN questions and pro tips to enhance your critical thinking and preparation for the NCLEX-RN. Make it your goal to level up your test-taking skills and confidence, so stick around, engage, and complete the practice tests.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX Review Crash Course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our Complete NCLEX Review Crash Course. The link is in the description. All right, now let's dive into the topic.
The first item that we have is a drag and drop Cloze test type, and this is all about newborn care. The scenario says the nurse is requested to attend the birthing suite to deliver care to a newborn immediately following delivery. The mother's history indicates uncomplicated gestational diabetes with natural labor onset. The pregnancy has reached 39 weeks and the mother plans to nurse the baby with breast milk. Your task is to select the most probable choices to complete the gaps in the statements below using the options provided. The nurse recognizes that the primary focus in this early care is to ensure effective blank. And the options that we have for blank one are temperature control, voiding, feeding, and breathing. The answer to this first blank is breathing. Why is it correct? It's because immediately after birth, the highest priority is to ensure the newborn is breathing effectively, and this is consistent with the Neonatal Resuscitation Program, or the NRP, which prioritizes airway, breathing, and circulation. And so if a baby who cannot breathe is at risk of hypoxia and death, so breathing must be established before addressing the other needs. Why is temperature control incorrect here? We know that this is important, but it comes after breathing is stabilized. We know that heat loss can be managed, but inadequate breathing must be corrected immediately first. Voiding is also incorrect because this is not expected immediately after birth and does not indicate that there is critical instability. Feeding is also incorrect. We know that it is also important, but this is not an immediate life-sustaining priority, and a baby must breathe first and be stable before initiating feeding. The next statement says standard practices involve securely positioning the full-term infant blank. The answer to this one is skin to skin with the mother. It's because this is a gold standard practiced in immediate newborn care for term stable babies. And this also improves temperature regulation. It supports early breastfeeding. It also enhances bonding and stabilizes the baby's respiratory and cardiac function. And this one aligns with the Baby-Friendly Hospital Initiative guidelines and the American Academy of Pediatrics, or the AAP. In the nursery option is also incorrect because this separates a healthy baby from the mother, which is not recommended. And we're supposed to allow rooming in, which will promote bonding and breastfeeding. In a swaddle is also incorrect, even though it helps with warmth, but it lacks the additional physiological and emotional benefits of skin-to-skin contact. Beneath the radiant warmer is also incorrect because this is reserved for unstable or preterm infants. not typically needed for a stable 39-week baby. The next statement says, after the initial evaluation, the nurse instructs the parents on newborn blank. The options are bathing, feeding cues, diaper application, and swaddling. The answer here is feeding cues, because this is all about teaching about the rooting hand-to-mouth movement, which will help the parents recognize when the baby is ready to nurse. And this is very critical for successful breastfeeding, especially when the mother intends to breastfeed. And so recognizing hunger signs before the infant cries can actually support responsive feeding, and it promotes bonding. Bathing is incorrect here because this is typically delayed 6 to 24 hours to preserve temperature and skin integrity. And this is not a priority teaching topic immediately after birth, especially compared to feeding for a breastfeeding mother. Diaper application is also incorrect, even though this is also important, but this is less urgent than feeding education, and it doesn't directly support the immediate breastfeeding goal, and this can be taught at a later time and also considered as a secondary need in this context. Now, what about swaddling? This is something that will be useful for comfort measure, but considered as secondary to feeding education, especially in the context of breastfeeding need. The last statement says, due to the mother's medical history, the nurse keeps a close eye on the infant for indications of blank. The options are low blood sugar, drug withdrawal symptoms, prematurity, and hyperbilirubinemia. The answer here is low blood sugar. It's because babies of mothers with gestational diabetes are at risk for hypoglycemia. The reason for that is because the mother's elevated glucose levels during pregnancy can cause fetal hyperinsulinemia, which persists after birth, and this results in low blood glucose when placental glucose is removed. And that's why we are supposed to monitor the clients or the pediatric patients' blood sugar levels during the first few hours of their life. And so the other options, such as hyperbilirubinemia, is incorrect. This is common in newborns, but not directly linked to gestational diabetes, and usually appears after 24 hours. Prematurity is also incorrect because the baby is born at 39 weeks, and this is not a factor this time. Drug withdrawal symptoms is also incorrect because there's no mention of substance use, and the neonatal abstinence syndrome would not be a concern unless maternal drug history indicated it. And so let's wrap up our answers for each blank. And so for blank one, the focus is about breathing because it's the immediate survival priority. And so the other options, such as temperature, voiding, feeding, are secondary. For blank 2, our focus is about skin to skin. This is correct for stability and breastfeeding support. The other options, such as nursery, swaddle, and warmer, don't match a healthy term infant's needs. And for blank 3, this is going to focus on the feeding cues, which is correct for breastfeeding education, whereas bathing, application of the diaper, and swaddling are less urgent this time. And for blank 4, our focus is about low blood sugar due to the gestational diabetes risk. And so the other options, such as the hyperbilirubinemia, prematurity, and withdrawal, don't fit the client history. Let's move on to the next item. This is a matrix multiple response. And the scenario involves the nurse attending to a 28-year-old patient admitted to the labor and delivery at 20 weeks and 4 days of pregnancy. The nurse's note says at 11:30, patient with a history of 6 pregnancies and 5 prior births describes experiencing vaginal bleeding and abdominal cramps starting 30 minutes before arriving. She notes the bleeding was more intense than a typical menstrual period. It started with a heavy flow and then tapered to a slight drip. She denies having a fever, chills, or heart palpitations, but mentions feeling lightheaded. She also states she hasn't felt fetal movement since this morning. Vital signs are temperature 98.4 degrees Fahrenheit, heart rate of 100 beats per minute, respiratory rate 18 breaths per minute, and blood pressure of 128/74, oxygen saturation of 97% on room air, weight 140 pounds, and fetal heart tones are steady, with a fetal heart rate of 140 to 150 beats per minute. At 12:45 p.m., healthcare provider is present at the bedside and has performed a vaginal exam. No signs of injury or cervical abnormalities observed. The cervical opening is visible with no ongoing bleeding. Small amounts of blood collect in the vaginal canal and gradually build up again after being cleared with large cotton swabs. The blood clots are noted. Now, I want you to pay attention to the laboratory test results. For the white blood cell count, we have a value of 8,200, hemoglobin at 10.8 grams per deciliter, hematocrit of 35%, and a platelet count of 255,000, and red blood cell count of 5.7. Your task is to decide whether the patient observation aligns with either miscarriage or placenta previa or both. So let's pay attention to the first observation, which says, states no sensation of fetal movement. What do you think about this one? Well, this is true to miscarriage and placenta previa. It's because there is going to be a decreased perception of fetal movement around 20 weeks, which can signal fetal compromise. And in the case of miscarriage, this is concerning because it may indicate fetal demise or distress, especially when accompanied by vaginal bleeding and cramping. However, in placenta previa, the reduced movement can also occur if the bleeding results in transient placental insufficiency, though fetal demise is less common at this stage unless bleeding becomes severe. Now let's take a look into the next observation. It says, absence of uterine contractions on monitor. This is true for a placenta previa because it typically causes painless vaginal bleeding without uterine contractions, especially this early in pregnancy. And the bleeding often happens due to the placenta's low implantation near or over the cervix. However, it's not really common in miscarriage, especially in the second trimester. And this is usually accompanied by uterine cramping or contractions as the body is trying to expel the dead fetal tissue. And since the patient reports cramping earlier, but no contractions are seen on the monitor later, this observation is more consistent with placenta previa. Now, for the third observation, it says lowered red blood cell count. So basically, we're talking about anemia here, which is going to be seen more in placenta previa because bleeding can be significant enough to reduce the maternal hemoglobin and hematocrit levels. So I want you to pay attention into the hemoglobin of 10.8. It's right here. So this is quite significant for this mother. And a drop of their hematocrit count of 35%. So here we go. This is something that you will expect when there is ongoing blood loss, especially in placenta previa. But why not for miscarriage? It's because even miscarriage can involve bleeding, but the degree is often less unless the miscarriage is complete or actively progressing. And in this case, since the bleeding is gradual and no tissue expulsion is noted, placenta previa is a better fit for the observed anemia. Now let's go on to the next patient observation. Steady fetal heart sounds. Well, this is true to the placenta previa. It's because in the scenario, it's said that the fetal heart rate is around 140 to 150 beats per minute, which is appropriate for this gestational age, and it indicates that the fetus is currently well oxygenated. And in placenta previa, the placenta may still be functioning normally, even with maternal bleeding. So it's common to find a healthy fetal heart rate here. However, it's nothing, it doesn't really matching to the miscarriage, especially when movement has already stopped and bleeding is present. And so you'd expect fetal heart rate tones to be present or abnormal if the fetal demise has already happened. Now let's move on to the next observation where it says bleeding from the vaginal area. Well, this is going to be true to both miscarriage and placenta previa. Because with miscarriage, the vaginal bleeding is a hallmark symptom, and it usually comes with cramping or uterine contractions as the maternal uterus is trying to expel the pregnancy. And for placenta previa, the bleeding is often painless. It can start suddenly, especially after physical activity or cervical manipulation. And in this case, the patient had bleeding with some cramps initially, and later findings showed ongoing slow bleeding but no active labor or contractions. And so the main key takeaway for this test item is that when you are evaluating an antepartum complication such as miscarriage or placenta previa, you have to focus on the patterns of the bleeding, the pain or the contractions, and the fetal movement and the fetal heart tones, because the NCLEX will often test your ability to compare similar symptoms across conditions. And so you have to really know the distinctive features of each to help you rule in or out the potential causes. Now let's move on into the next item here, which is a bow tie. So this is something about a endocrine disturbance here. And so here we have our case of a nurse attending to a 46-year-old patient in the emergency department. And the progress note says at 13:55, patient arrived at the emergency department accompanied by family, reporting abrupt onset of intense headache, lightheadedness, heart palpitations, and widespread weakness. And there is history of COVID-19 last week managed at home. Patient is fully vaccinated and boosted against the virus, alert and oriented to person, place, time, and situation. Lung fields are clear on auscultation, heart sounds, S1 and S2 audible, no murmurs detected, bowel sounds active in all four quadrants, extremities move on command, capillary refill less than 3 seconds, and vital signs temperature 98.8 degrees Fahrenheit, heart rate of 96 beats per minute and irregular, respirations 22 breaths per minute, blood pressure of 86/48, and stat labs ordered and collected, peripheral IV line inserted in left forearm. Your task is to fill in the diagram by choosing from the options provided to identify the potential condition the patient may be experiencing, 2 suitable nursing interventions, and 2 parameters to monitor to assess the success of the nursing interventions. Now, we have the options for potential problems or conditions. We have Cushing syndrome, acute adrenal insufficiency, hypercortisolism, and hyperthyroidism. So what do you think is the best answer? The correct answer here is acute adrenal insufficiency. Why? Well, let's connect the dots here. In the scenario, it said that the patient has hypotension. The blood pressure here is 86/48. Pay attention to this one. And there's also fatigue and widespread weakness, plus a recent infection of COVID-19 last week, which is a physiological stressor. And the sudden onset and the combination of cardiovascular and neurological symptoms point to something that is systemic. And so, given the absence of fever, take a look into the temperature. It's quite normal here. And there is also normal oxygenation. There's no mention about that. And the respirations of 22 is slightly higher, but it's not really significant. The lungs are actually clear upon auscultation. So we'll rewind this one. And there are no murmurs detected. S1 and S2 are audible. And that is nothing really significant, but I just want you to keep in mind that there is no mention about hypoxemia. And when you are selecting adrenal insufficiency, this is something that can be triggered by a stressor, especially an infection. And especially if there was a pre-existing adrenal dysfunction or an unrecognized adrenal suppression. And remember that in adrenal crisis, the adrenal glands fail to produce enough cortisol and aldosterone, which are essential for maintaining the blood pressure and balancing the electrolytes and also stabilizing the blood glucose. So, if you were going to ask, what happens when the person is deficient about the needed electrolytes? They're going to end up with a hypotension, right? Because of low aldosterone. This is not going to help them retain the sodium and water. And they also have electrolyte imbalances, such as hyperkalemia and hyponatremia. And in this patient, expect that there is going to be hypoglycemia because cortisol is also diminished. And we know that this is very critical for gluconeogenesis. And the patient's vague symptoms like weakness, dizziness, and fatigue are all part of the picture. Now, why are the other options incorrect, such as hyperthyroidism? Why is this X'd? Well, remember that with hyperthyroidism, a person will have hypertension, not hypo. And you would expect heat intolerance, there's going to be tremors, weight loss, and anxiety, which are not present in the case. And the heart rate might be fast, but it's usually regular, not irregular. So take note of the differences. Now take a look into the next option, which is hypercortisolism. This one over here. This is also incorrect. And why is that? Remember that with that condition, this is resulting from excess cortisol. This is going to lead to hypertension. There's going to be weight gain. There's going to be moon face and hyperglycemia, which is opposite to the patient's hypotension and weakness. And in hypercortisolism, this is something that you would expect as a chronic condition, not really similar to an acute crisis like we have in this case. Now, the next item is Cushing's syndrome, which is quite similar to the hypercortisolism. And I want you to recall the features of this disorder. This can also lead to hypertension. There is weight gain. There is moon face and hyperglycemia, which are all opposite to the patient's hypotension, weakness, and other acute manifestations. And if this is true to the patient, then they're going to end up with easy bruising. There's also buffalo hump, and none of those are being mentioned in this case. So we are going to get rid of that Cushing syndrome. Now let's move on into the nursing intervention. So one of those interventions is to administer IV corticosteroids as per the guidelines. Why is this correct? Well, remember that our client is deficient of the cortisol. They also lack the aldosterone. So this treatment will basically treat or immediately treat the deficiencies that are noted in this patient's condition. Again, we are replacing cortisol and aldosterone, and this will correct the hypotension, the hypoglycemia, and this will also prevent further deterioration. Again, look back into the manifestations of hypotension and the widespread weakness. Now, why are the other interventions incorrect, such as giving, let me provide you the other answer, which is basically the administration of IV dextrose combined with insulin. Why is that correct? Well, remember, in acute adrenal insufficiency, there is hypoglycemia due to the deficiency of cortisol, which impairs glucose production. And the IV dextrose will treat the low blood sugar, while the insulin is intended to allow the influx of excess potassium from the bloodstream to go inside the cells temporarily. So that is why this is a combination of both the glucose and the insulin. So this will stabilize the metabolic disturbances and also a priority intervention in the crisis. Now, what about the administration of oxygen? Why do you think this is incorrect? Well, I want you to go back to the scenario. There is no evidence that the client is hypoxemic, and go back into the respirations. It's 22. It doesn't really warrant the administration of oxygen here. And again, if there is no evidence of hypoxemia, you're not going to administer supplemental oxygen. Now let's move on into administration of potassium-sparing diuretic. Why is this incorrect? Well, if we are mentioning this type of intervention, this refers to the administration of aldactone or spironolactone, but these two medications are not indicated here because with acute adrenal insufficiency, they tend to have hyperkalemia, and we don't want to worsen that condition. And remember that the potassium-sparing diuretic will only worsen the hyponatremia here, and it will worsen the hyperkalemia. So we are not going to use that intervention. Now, what else? We have arranged for a CT scan of the head and neck. Why is this incorrect? Well, even though the scenario stated about the severe headache, which might suggest a neurological issue, but the full clinical picture here, the hypotension, the irregular heart rate, the weakness, and the recent illness points to the adrenal crisis. It's not about a structural brain problem. And this is something that you can consider later to rule out pituitary causes of adrenal insufficiency, but this is not going to require much immediate priority or action compared to the other interventions that we have already selected here, which is all about acute adrenal insufficiency. So we are actually worried about the Addison's crisis here, which is a life-threatening emergency. Now let's move on into the other part of the Bowtie, which is the parameter to monitor. So what do you think are those two parameters? We have the options: patient's body weight, oxygen saturation, heart rate and rhythm, levels of serum electrolytes and glucose, and intensity of headache and pain. So one of those answers is basically the heart rate and rhythm. And why are we going to select that? Well, remember that the client has irregular heart rhythm, right? And this is attributed to the electrolyte imbalance, hyperkalemia. And remember that with adrenal insufficiency, this can cause tachycardia due to the hypotension and the stress on the cardiovascular system. And so when we are monitoring both the heart rate and the rhythm, this will help evaluate the effectiveness of the medications that we have administered. which is the dextrose combined with the insulin to treat the hyperkalemia, and also the administration of the corticosteroids to address the hyponatremia and also to address the hypotension. Now, the other answer we have is levels of serum electrolyte and glucose, because we know that in adrenal crisis, it disrupts sodium, it disrupts potassium and glucose levels due to the cortisol and aldosterone deficiency. And you have to monitor these lab values to ensure that the nursing actions that you have done to your patient are effective and helping the patient to recover from these life-threatening symptoms. So, the patient's body weight is incorrect. It's because it's not a priority in the acute phase of adrenal insufficiency. Even though that an adrenal issue could be chronic, it might affect their weight, but this acute condition focuses on the immediate stabilization of the vital signs and their lab values. We're not taking care about the long-term trends like weight changes at the moment. Our focus here is all about circulation issue. Now, another parameter that is incorrect is oxygen saturation, because the scenario does not indicate respiratory compromise. As mentioned in the scenario, the client has clear lung sounds, respirations at 22 breaths per minute. And remember that adrenal insufficiency primarily affects the metabolic and cardiovascular systems. It doesn't affect much the respiratory function. Another incorrect option here is intensity of headache pain. We know that this is one of the presenting symptoms, but this is likely secondary to hypotension or the metabolic stress in the adrenal crisis. And monitoring the pain does not directly assess the effectiveness of the two interventions that we have done for the patient. So for this case, I want you to strategize in analyzing the scenario, make it systematic, and so you can use the airway breathing circulation framework. And so when you do this, focus first on the airway breathing. You got to ask about the airway. Is it obstructed? Is the breathing compromised? Well, the respirations is about 22. It doesn't really reflect immediate respiratory distress, and so you're going to rule that out. And so proceed with the circulation this time. Take note about the blood pressure that is 86/48. That is very significant. And the irregular heart rhythm, there's also slight tachycardia, which are significant red flags. And with the hypotension, it can also cause some headache. It can lead to dizziness, the palpitation, the weakness, and also the recent COVID-19 stress. So I want you to highlight those abnormal vital signs. Next, what you're going to need to do is to match those symptoms to the condition. Use the process of elimination for the potential condition. And so you have to compare the symptoms and the vital signs to each option. So remember about the acute adrenal insufficiency. It relates more to hypotension, irregular heart rate, weakness, dizziness, and the post-viral trigger, which matches well. And for the hyperthyroidism, what you're going to expect is hypertension, there's regular tachycardia, heat intolerance, which doesn't fit here, and the hypercortisolism and the Cushing's, which are all about chronic hypertension. There's weight gain, but not acute or hypotensive. So my tip for you here is to rule out those conditions with opposite presentations. So the other options will manifest hypertension, not hypotension. Now for the interventions, I want you to select those based on the pathophysiology. So we have the correct choices: administration of steroids, which will replace the missing hormones. It will help stabilize the blood pressure. And the administration of dextrose with insulin will also correct hypoglycemia. It will manage the hyperkalemia. And so you can readily eliminate the supplemental O2, eliminate the potassium sparing diuretic, and the CAT scan is not urgent for adrenal crisis. Now for the parameters to monitor, make sure that those two will coincide with the nursing intervention. So what we should be selecting here are the heart rate and rhythm and the serum electrolytes and glucose, which will help you evaluate the effectiveness of those two nursing actions. And don't forget about using time management. We are supposed to focus on the sudden onset. So we are going to prioritize acute conditions and interventions. So you should pay attention to the keywords about abrupt, which suggests crisis. We're not talking about chronic, such as Cushing's or hypercortisolism. You have to take note about the vital signs clues, the hypotension, the irregular heart rhythm, which points to adrenal or cardiac manifestations. And make sure that you select all these keywords, such as acute or sudden, to help guide you in selecting those urgent nursing interventions to target the potential problem.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX Review Crash Course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX Review Crash Course. The link is in the description. Now, let's continue with the topic.
Let's move on into our fourth scenario. This is drop down in a table, all about gastrointestinal disturbance. So the case scenario mentions a 52-year-old man arrives at the emergency department complaining of difficulty breathing, nausea, vomiting, and signs of dehydration. According to the client's partner, he was diagnosed with cirrhosis 4 years prior to excessive alcohol consumption, despite warnings that continued drinking would worsen his condition. The client persists in consuming 4 to 6 vodkas nightly, with increased intake during special occasions or celebrations. He is subsequently moved to the medical unit, where the nurse develops a care plan to prevent and watch for possible complications related to cirrhosis. So your task here is to identify the associated possible complications for each assessment finding of liver cirrhosis by selecting the option in the drop-down menu. So here we have the assessment findings: stomach discomfort and elevated temperature, difficulty breathing, vomiting blood, persistent constipation, abrupt reduction in urine production, reduced awareness and disorientation, skin with a yellowish tint. So what do you think will match to our first assessment finding? Stomach discomfort and elevated temperature. Well, the options here are the following. We have spontaneous bacterial peritonitis, bleeding esophageal varices, portal systemic encephalopathy, jaundice, hepatorenal syndrome, none. The answer here is spontaneous bacterial peritonitis. So this is actually an ongoing infection. And this is a common complication of cirrhosis due to ascites and impaired immune function. And it presents with abdominal pain, there's stomach discomfort, fever, and often without obvious signs of peritonitis. And the patient's cirrhosis and systemic symptoms could be associated with nausea can also support this as a plausible complication. Now, why not bleeding esophageal varices? It's because bleeding varices cause hematemesis and hemodynamic instability. There's hypotension, not primarily fever or abdominal pain, unless secondary infection occurs, which is not indicated here. And portal systemic encephalopathy doesn't match because this condition affects mental status. There's going to be confusion, not abdominal pain or fever, unless it's complicated by an infection, which is not the primary finding. And the jaundice is also incorrect in this assessment finding because this can cause yellowing of the skin, the eyes, due to the bilirubin buildup, not about abdominal pain or fever. And the the hepatorenal syndrome is also incorrect because this one can lead to reduced urine output, renal dysfunction, not abdominal pain or fever as primary symptoms. Now let's move on to difficulty of breathing. What do you think can be matched here? Well, the answer here is going to be none. And the reason for that is because difficulty breathing doesn't directly, it's not tied to a specific cirrhosis complication that is listed. And this could be due to the dehydration, anemia from bleeding, or maybe a separate issue. It could be pulmonary edema, but none of those options directly explain it. And cirrhosis-related dyspnea might occur in hepatopulmonary syndrome, which is not listed in the options, but the scenario lacks supporting evidence. Now let's move on into our third assessment finding, which is vomiting blood. The answer here is bleeding esophageal varices. It's because hematemesis is a classic sign of bleeding esophageal varices, which is frequently a life-threatening complication of cirrhosis due to portal hypertension. And the patient's history of alcohol-related cirrhosis increases this risk. And so the other options, such as spontaneous bacterial infection in the abdomen, doesn't really match that. We know that the spontaneous bacterial peritonitis causes abdominal pain and fever, but not upper GI bleeding like hematemesis. Now for the fourth observation, we have persistent constipation. The answer to this one is none, because persistent constipation is not a hallmark of any listed cirrhosis complications. Even though cirrhosis can affect gastrointestinal motility indirectly, constipation is not a primary feature of these acute issues. And it could be incidental or unrelated to the cirrhosis complication in this case. Now let's go into our next observation, which is abrupt reduction in urine production. This is linked to hepatorenal syndrome. So this is a severe cirrhosis complication wherein there is now a problem with kidney perfusion due to the vasodilation and portal hypertension leading to the oliguria, and the patient's dehydration and cirrhosis history also support this one. And so the rest of the options here are incorrect. Now let's move on into our next observation, which is skin with a yellowish tint. Well, obviously the answer to that will be, hang on a second here. We have reduced awareness and disorientation. So the answer here is portal systemic encephalopathy. And this is something that can happen when there is a buildup of ammonia, which crosses into the blood-brain barrier. It will lead to neurological symptoms like confusion and a reduction in the level of consciousness. And this is related to the patient's chronic liver damage, and their alcohol use will also worsen this. And remember that this is all about the crossing of the ammonia into the blood-brain barrier, and that's why they're going to end up with encephalopathy. There is going to be disorientation, And in some cases, they will become combative and so confused. Now, the last manifestation is skin with a yellowish tint. The answer to that one is jaundice. It's because of the impaired liver bilirubin processing. It can cause that yellowish pigment of the skin and also the sclera, which is very evident with chronic liver damage. And so I hope that you were able to match all those clinical findings with the cirrhosis complications. Let's have our item number 5. So this is a highlighting the significant findings in the table. So the scenario is about a 58-year-old male patient with a 15-year history of type 2 diabetes mellitus visiting the primary care provider, noting a reduction in urination frequency and volume over the last month, despite drinking more fluids. The client mentions a weight gain of 5 pounds in the past month without altering diet or eating patterns. The client maintains a consistent exercise routine and blood sugar levels are typically stable. The provider requests blood tests and the serum lab results are as follows. So your task is to identify which of the client's lab test findings should raise concern for the nurse. So we have hematocrit of 37, hemoglobin of 12.6 grams per deciliter, bicarbonate of 25 milliequivalents per liter, phosphorus of 4.8 milligrams per deciliter, calcium of 9.4 milligrams per deciliter, potassium of 5.4 milliequivalents per liter, sodium of 133 milliequivalents per liter, creatinine of 2.7 milligrams per deciliter, and blood urea nitrogen of 36 milligrams per deciliter. So, you should be worried about the hematocrit count, which is 37%. Usually, it should be around 38 to 50%. And the finding that we have is slightly below normal. It suggests a mild anemia. And so in a client with a long-standing type 2 diabetes mellitus and reduced urination, this could indicate early renal dysfunction because of decreased erythropoietin production by the kidneys, which is a common complication of diabetic nephropathy. Even though not severely abnormal, but it reflects attention given the clinical context. And you should be concerned here because when combined with the other renal labs, such as the elevated creatinine, it supports a pattern of kidney involvement. So this could have been going on for quite some time. The next significant finding that you should highlight is the hemoglobin of 12.6. And the expected normal range for the hemoglobin is somewhere between 13.5 to 17.5 grams per deciliter. And so this hemoglobin level is below normal. There is mild anemia. And again, take a look into the client's history of type 2 diabetes. It can impair the kidney function, which reflects that there is going to be impairment of erythropoiesis. And so this is signaling you that there is already a ongoing chronic kidney issue. Remember that the creatinine is already high here. Now, take a look into the other labs, especially the potassium of 5.4. This is hyperkalemia. This is concerning because hyperkalemia often occurs when there is impaired kidney problem or impaired kidney function due to the diabetic nephropathy, especially that we have an elevated creatinine level. And so this will lead to cardiac arrhythmias if we are not going to intervene this one. The next manifestation is sodium level of 133. We normally have it set at 135 to 145. So this reflects hyponatremia. So in this client, it could reflect fluid retention as evidenced by weight gain despite an increased fluid intake and reduced urination. And possibly this is associated to the renal dysfunction or the heart failure, both in type 2 diabetes complications. And this is something subtle but notable abnormality. Now, we have the obvious creatinine level of 2.7. Normally, it should be around 0.6 to 1.2 milligrams per deciliter. This is significantly elevated, so this indicates that there is already ongoing kidney malfunction. And this could be a complication from the reduced kidney function here. And so there is possibly diabetic nephropathy that has been going on for quite some time, and this will require urgent attention. Now, lastly, we have the blood urea nitrogen of 36 milligrams per deciliter. We know that the usual range is around 7 to 20 milligrams per deciliter, and this is elevated. So this reflects reduced renal clearance of urea, and which is consistent with high creatinine and the low urinary output. So this is a key indicator of renal stress or dehydration, which is both concerning in this context. And so we have the other options: bicarbonate, 25 milliequivalents. This is within the normal range, so we're going to discard this one. The client in this scenario has no evidence of metabolic acidosis or alkalosis or Cosmos breathing. There's no other supporting ABGs, so we're not going to be worried about this one. For the phosphate, we have a value of 4.8 milligrams per deciliter. This is slightly elevated, but not a primary concern in early renal dysfunction unless it's significantly higher. The usual range is usually at 2.5 to 4.5 milligrams per deciliter. Again, like I have said, it is slightly higher, but in a client with a CKD or chronic kidney disease, the phosphorus rises later as the kidneys fail to excrete it. But this mild increase in the lab doesn't yet warrant alarm compared to the creatinine and the BUN. Now, for the calcium of 9.4, we are still within the normal range. Remember about the range of 8.5 to 10.2 or 10.5 milligrams per deciliter. And this is not indicating an issue at all. And there are no other manifestations that will support a problem in the calcium regulation. So I hope that you're able to catch this.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included: 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX Review Crash Course. The link is in the description. Now, let's jump into the topic.
Now let's move on to our last item. Here we have a matrix multiple choice, and this is also an endocrine disturbance. So the scenario says A 64-year-old woman who experienced hyperglycemic hyperosmolar state syndrome, or the HHS, 3 weeks ago is being brought by her husband to the primary care provider today for a follow-up appointment. Your task: for each patient observation, determine if the interventions from her hospital stay were effective, ineffective, or irrelevant. So we have the patient observation. So let's go through each of these. The first one, it says skin turgor within normal limits. Well, obviously, it is effective, right? Because it indicates adequate hydration, which is a key goal of the hyperosmolar hyperglycemic syndrome. And remember, with HHS, it causes severe dehydration due to the osmotic diuresis from hyperglycemia. And if the client has had IV fluids as part of the hospital interventions, this is aimed to correct the dehydration. And so normal skin turgor 3 weeks later suggests a successful rehydration that has been maintained. And so if you selected ineffective, that's incorrect, because it would imply persistent dehydration, poor skin turgor, which is not the case here. And also, irrelevant is incorrect, because skin turgor directly relates to hydration status, which is a primary HHS outcome, so it's not unrelated. For the next observation, has had difficulty hearing in her left ear for the past 3 days. The answer to this is irrelevant, because hearing difficulty starting 3 days ago is not a typical symptom of outcome of the HHS or its treatment. And remember that HHS affects glucose, hydration, and mental function. Okay, so we are going to eliminate that. Now let's go into our next observation, which says developed constipation 4 days ago. The answer here should be irrelevant, because this is not a direct outcome of HHS or its treatment. And the HHS interventions focus on glucose control, hydration, and electrolytes, not about bowel function. So this is something that could be due to dietary changes or medications, or other unrelated gastrointestinal issues after the discharge. But then again, it's not linked to the hospital care goals. Now let's move on to our fourth observation, which is feel stronger over the past week. Well, obviously that is effective, because it reflects improved overall condition, likely due to resolution of the HHS related weakness from the dehydration or hyperglycemia and metabolic stress. And with hospital interventions such as administration of insulin or fluids, this can help restore the energy and the client's function. And this subjective improvement also aligns with the expected recovery outcomes. Now let's go into our next observation, which is blood glucose finger stick before breakfast, which is 116 milligrams per deciliter. So this is reflecting effective intervention, because this is within the normal range, especially for this patient that may have a type 2 diabetes. And remember that with HHS, it involves extreme hyperglycemia, which is greater than 600 milligrams per deciliter. And usually with hospital insulin therapy, this is aimed to normalize the glucose. And so this results 3 weeks later, it indicates effective long-term glucose control after the treatment. Now let's have our next item, which is alert and oriented to person, place, and time. This is also indicating effective treatment, because with HHS, it often causes altered mental status. There's going to be confusion, coma, due to the hyperosmolarity and dehydration. And in this case, being alert and oriented 3 weeks later, it indicates that the interventions have successfully restored neurological function, which is a key expected outcome. Now, for the blood pressure of 145/86, what do you think about that one? This is reflecting ineffective treatment because remember that with HHS, it often presents with hypotension due to the severe dehydration and treatment. And the IV fluid therapy in the hospital aims to restore normal blood pressure, which should be around the safe range. But a blood pressure this high, 145/86, 3 weeks later, suggests that there is mild hypertension, which may indicate incomplete resolution of fluid balance, or maybe a pre-existing condition that has not been fully addressed by the HHS intervention, even though it's not that critical, but it deviates from the optimal post-treatment of blood pressure. Now let's take a look into the last one here. It says, has resumed a normal urination pattern. What do you think about that? Well, this reflects effective treatment because when there is resumption of normal urination pattern 3 weeks after, this reflects that there is restoration of the kidney perfusion and hydration, which is a direct result of hospital IV fluids and glucose management. And remember that with HHS, it causes polyuria initially, then oliguria as reflective about a worsening dehydration. So this is a huge improvement here. Now, you have to eliminate the other option. It's not ineffective because if there is persistent abnormal urination such as oliguria, it could suggest that there is a failure of the intervention, whereas being irrelevant, it simply means that urination reflects, the urination doesn't really relate to it, which is not appropriate here. So again, do not forget about the manifestations that will reflect effective treatment after the client has been admitted for the HHS. So again, our focus here is to check about the restoration of the client's skin turgor, which directly aligns with hydration status that has been normalized, and the patient feeling a lot stronger over the past week, which is a sign that there is now restoration of the fluid volume, and the patient's blood sugar level somewhere around 116, even though it's not really that normal. But with this case, the client has had a history of HHS, so expect that previously the patient's blood sugar could have been skyrocketing in the high 600s. So this is quite a huge improvement. And the patient's alert level and their orientation to person, place, and time, that's a huge improvement as well. As we know that with HHS, this can lead to confusion and even coma as well. And the patient's resumption of normal urination pattern is also a good reflection that the patient's hydration status has also normalized. And so that's the end of our Q&A today. I want you to reflect on what you've learned and tackle those practice questions one more time, and keep practicing all the test questions that you have gone through in the previous videos. Now, if you found this session helpful, give it a thumbs up and subscribe for more NCLEX prep resources. Also, let us know in the comments how you fared with these practice questions, and we'll catch you on the next video. Thank you for watching.